Good afternoon, everyone. My name is Dr. Goutami, one of the consultant neonatologist and pediatrician at Cuddles, Kondapur. Today, I want to discuss about antenatal Dopplers and its usefulness in managing the preterm babies. So, what a neonatologist should know about the antenatal Dopplers in day-to-day practice. So, antenatal Dopplers, what information it gives for us is it gives the information of the fetal well-being, how the blood circulation to the fetus is there throughout the pregnancy, how the uteroplacental unit is functioning. So accordingly, we can anticipate the problems in those preterm babies and we can manage accordingly. Like in case of absent and reverse and diastolic flow babies, there will be brain sparing effect and there will be relative decrease in the, the decrease in the blood flow to the gut, that is ischemia will be there, mesenteric ischemia. So we should go slow on the feeding in those babies. And not only in IUGR, it will helps us in few more conditions, such as in case of fetal anemia. We will follow up the babies with the Dopplers and will decide when to give the intrauterine transfusions, all those things. And in case of twin-to-twin transfusion syndrome, also we will see means how much is the twin-to-twin discordance is there, and will act accordingly. So, and in case of RH isoimmunization, also the Doppler velocity has will have good prognosis and compared to the invasive tests such as amniocentesis and choriocentesis. So what is Doppler ultrasound? So the red cells so the red cells moving in the circulation will create the sound waves which are taken up by the Doppler ultrasound machine, and it will give the picture. So we can know the presence and we can know the direction of the flow, velocity of the flow, and volume of the flow, and any impedance to the circulation is there, that is resistance, or is it a pulsatile flow or a normal flow, like that. So first, we'll recapitulate the uteroplacental unit. This is a uteroplacental unit. During the early pregnancy, the uterine artery uterine artery will have spiral arteries, and this is the maternal residual tissue, and this is the placenta with syncytiotrophoblasts, and these are the cytotrophoblast, and these are the umbilical vein and artery of the fetus. So here the blood will come from the maternal side through the spiral arteries, and here the gas exchange will occur. So initially the spiral arteries are very small in caliber, and they are very tortuous. So during throughout the pregnancy, the spiral arteries will undergo the remodeling. From these tortuous spiral arteries, they will become a tunnel-like or funnel-like spiral arteries. So initially they will be very tortuous, and as the pregnancy has been as the gestational age increases, the spiral arteries will undergo the dilatation, and meanwhile there will be invasion of the cytotrophoblast into the maternal residual tissue. So the cytotrophoblast not only invades the maternal residual tissue, they also invades the spiral arteries. So this is also an important step, because so if the spiral arteries are dilated, so there is a gush of blood goes from the, will be going from the maternal side into the placental side. So placenta is relatively oxygen deprived tissue. It grows in low oxygen concentration only, and high blood flow will be detrimental. So this trophoblastic invasion is essential in the early gestation. As the gestational age increases, these cytotrophoblasts which are invaded in the spiral arteries, they will undergo the canalization, and a funnel or tunnel-like structure will form. This is a dilated and remodeled spiral artery. So the blood will flow in these spiral arteries, and due to the dilatation and very big caliber, the velocity of the blood will also be normal. It is not an increased velocity. The blood flow will be maximum, but the pressure required will be the minimum. So means any defect in the recanalization of these trophoblastic plug, or any defect in the formation of the tertiary villi or invasion of the cytotrophoblast into the residual tissue will result in decreased nutrient supply from the mother to the baby, causing early placental insufficiency, leading to early onset IUGR. So we are doing Doppler studies for a mother. So it is essential to do Doppler studies for all mothers, or in the high risk cases only we should do. So in a Cochrane review, they found out that there is no incidence in the intrapartum fetal distress and cesarean section in the Doppler group and non-Doppler group of mothers, but there is a definite decrease in the perinatal death, labor inductions in case of Doppler and non-Doppler group. So if the pregnancy is high risk, we should do the Dopplers mostly. If there are no risk factors, just we can monitor them. So Doppler velocity guides will give the information when to how frequently we should monitor. How frequently we should monitor the mother. And they are useful in identifying the SGA fetuses which do not require intensive monitoring like FGR. Means fetal growth restriction and short for gestation. These two are not synonymous. Short for gestation age means their weight will be less than 10 centile, but means they don't have complications or any chromosomal disorders as in case of intrauterine growth restricted fetuses, and the complications and morbidities are more with IUG or FGR babies. So we will avoid unnecessary invasive test prenatally and postnatally also by doing the Doppler studies. Because in SGA fetuses, they will small, but the Doppler velocity indices, all these will be normal. In case of fetal growth restriction, the indices will be high. So Dopplers, what are the information we'll get from Dopplers are we'll do Dopplers in case of mother with preeclampsia to see how the uteroplacental unit is functioning, in insufficiency is there or not, how is the hypoxic insult of the fetus, and how the fetus is adapting to the hypoxia, is the brain sparing effect is there, and to plan the delivery time, and in case of RH isoimmunization also we will see how the Doppler velocities are there, and in case of twin-to-twin transfusion syndrome, we'll see how the recipient and donor twins are doing, how much is the discordance, and any need for intrauterine transfusion in case of donor twin, in case of fetal anemia, by seeing the middle cerebral artery peak systolic velocities. So overall Doppler will reduces the perinatal mortality. So what are the various vessels we will examine in the antenatal Dopplers? So one uterine artery, umbilical artery, middle cerebral artery, and the venous system. Arterial system, these three, and in venous system, umbilical vein, inferior vena cava, and ductus venosus. So uterine artery, this is maternal uterine artery. So we will see how the maternal means any resistance is there from the maternal side, that is flow resistance to the uterus is there or not, we will see. Umbilical artery, we will see the placental flow resistance, how the placenta is invaded the maternal residual tissue. Is there any impedance to the flow is there or not? We will see. And this is the most prognostic and important Doppler, that is umbilical artery Doppler. And another thing is middle cerebral artery of the baby. Here we will see the fetal adaptation to the flow resistance change. That is, in case of fetal growth retardation or IUGR, there will be brain sparing effect. That is, the important organs like brain, adrenals, and kidneys will receive the brain. And the remaining organs will receive the less perfusion. That is, there will be increased MCA flows. That is, there will be increase in end-diastolic flow in the middle cerebral artery. And the venous system, we will look for umbilical vein, how are the Dopplers, ductus venosus, and inferior vena cava. So the blood from the means umbilical vein, it goes to the ductus venosus, and from there to the inferior vena cava, and from there to the right atrium and right ventricle. So it indirectly tells about the fetal cardiac function. Especially the ductus venosus Dopplers will give the indirect marker how the right heart is functioning in the fetus. So what are the indices? We'll look that one is peak systolic flow velocity, also abbreviated as S, end diastolic flow velocity, abbreviated as D, and average flow velocity over the cardiac cycle, that is A. So these three values we will calculate, and after that we will do the indices. I will show you. One is peak systolic to end diastolic flow ratio, that is S by D ratio. This is the diagram. This is one cardiac cycle from systole to diastole, from here to here. This upward projection will be the systole, and this one will be the diastole. So peak systole means this is the highest part of the systole. This is known as peak systolic velocity, predicted as S. This is end diastolic velocity, predicted as D, and this is the temporal means A, that is temporal average frequency over the one cardiac cycle, that is mean. And this is the velocity, mean velocity, how the velocity of the blood flowing those in that vessel. So, we have three indices. One is S by D ratio, that is simple, peak systolic velocity by end diastolic velocity. As the gestational age improves, the impedance to the blood flow will decrease, and there will be more flow in the diastole. So the D increases. So as the denominator increases, the ratio should decrease. So after 28 to 32 weeks, if the S by D ratio should normally decrease. If it increases or is more than 2.5, more than 3, it is considered abnormal. And resistance index is peak systolic velocity minus end diastolic velocity by systolic velocity, peak systolic velocity. And it should also decrease as the gestational age advances. And pulsatility index, that is also peak systolic velocity minus end diastolic flow by average temporal average frequency over the cardiac cycle. The pulsatility index should also decrease as the gestational age advances. So what is the importance of pulsatility index is, if the end diastolic flow is absent, we can't calculate the resistance index. In that case also, we can calculate the PI. So these are the three indices, S by D ratio, pulsatility index, resistance index. So S by D ratio should decrease, pulsatility and resistance index, all means all the indices should decrease as the gestational age progresses. So normally will come to the umbilical artery Dopplers. The feto-placental vascular system continues to expand with advancing gestation, which ensures sufficient placental nutrient and oxygen transfer to the support fetal growth. Feto-placental arterial impedance progressively declines and umbilical blood flow progressively increases. So end diastolic flow of the fetal cardiac cycle is noted by 14 to 16 weeks of gestation and progressively increases, thus providing an uninterrupted supply of nutrients and oxygen to the growing tissue throughout the cardiac cycle. So this is the wave panels organized according to gestational age, from starting 16, 20, 24, 30, 28, and 32, and 36, and 40 weeks. So in the early gestation, there is the systole, diastole. See, there is no diastolic flow only. So as the gestation age increases, the diastolic part slowly it will increase. See here, it is there, and here also it has been increased. Here increased. So in umbilical artery, so as the gestational age advances, the resistance will decrease, and there will be increased flow of blood during the diastole. So the diastolic component increases. This is a normal phenomenon. So the umbilical artery Dopplers are the only index having diagnostic and prognostic role, and worsening of the Doppler parameters, that is absent end diastolic flow or reverse end diastolic flow, they will present at least 1 week prior to the deterioration. So clinical deterioration will be preceded by the Doppler abnormalities, and this reverse end diastolic flow, it will have a sensitivity and specificity of 60% for adverse perinatal outcome. And by doing the umbilical artery Dopplers, there is a 29% reduction in the perinatal mortality in the high-risk pregnancies observed. So what happens in umbilical arteries, as there is uteroplacental insufficiency, initially there will be decreased diastolic flow, that is increased resistance will be there. Due to that, there will be decreased diastolic flow. After decreased diastolic flow, there will be absent end diastolic flow, and after that, last step will be the reversal of the end diastolic flow. So this reversal of end diastolic flow indicates impending morbidity and mortality in the babies, and sensitivity and specificity of 60% will be there. And there are some technical, physiological, and pharmacological factors which influence the diastolic flow and Doppler images, like angle of insonation. It should be aligned as close to the zero. There should not be any angle of insonation, and sampling site. The indices will be higher if you do with the fetal abdominal end and the placental end of the cord. And wall filter we should use to minimize the errors. Physiological. So fetal heart rate influences the arterial Doppler, but within normal limits of fetal heart rate, that is 120 to 160, the changes were very clinically insignificant, and we should avoid Dopplers when the baby is hiccuping or during movements or breathing or hiccups. And as the gestational age increases, due to normal expansion of the fetovascular bed, there will be decreased fetoplacental flow impedance. So early in the pregnancy, there will be some impedance will be there, but later towards the end, the impedance will decrease because the flow should increase. And pharmacological factors, antenatal steroids, there's several reports that they have observed that there will be improvement in the umbilical artery Doppler after giving the dexamethasone or betamethasone, but changes are very transient and they do not impact any outcomes. Magnesium sulfate also will reduce the umbilical artery pulsatility index, but its prognostic significance remains insignificant. So how to interpret the umbilical artery Dopplers? One is quantitative, another is qualitative interpretation will be there. Quantitative means numbers, that is an S/D ratio, that is peak systolic velocity to diastolic end diastolic flow ratio. If it is more than 3 or resistance index more than 0.6 at more than or equal to 28 weeks of gestation is the best single point threshold for identifying the pregnancies at high risk of adverse outcome. So normally the S/D ratio, RI and pulsatility should decrease, but if they are more than 3 and resistance index is more than 0.6 at more than or equal to 28 to 30 weeks of gestation, there is so we should intervene the pregnancy. Another common approach is to use Doppler index greater than the 95th percentile for the gestation age as the threshold for abnormal umbilical artery Doppler. So for all umbilical arteries, uterine arteries, and MCAs, ductus venosus, all the reference charts for the nomographs will be there. We should plot on them, and if it is more than 95th percentile, we should intervene the pregnancy. This is the umbilical artery pulsatility index. As the gestational age increases, it should decrease. Another one is qualitative interpretation. Absent and reverse and diastolic flow in the umbilical artery are the sign of fetal-placental circulatory deterioration due to increased impedance, vascular impedance to the flow, and associated with adverse perinatal outcomes. And it is estimated that more than 70% placental arteries are obliterated in the reverse and diastolic flow. So if 40% of the placental arteries are obliterated, then the fetal will be growth restricted. But in Dopplers, if it is more than 70% only obliterated, it is more than 70% obliteration is required to show the features of reverse and diastolic flow. So reverse and diastolic flow is an ominous marker of imminent fetal death. So this is the diagram of umbilical artery. This is the systole. This is the diastole. Normally the systole should be like this and systole should be like this and diastole should follow like this. Here the diastole has been came down to the line, below the line, that is reverse and diastolic flow. This is another diagram showing that this is the systole, but there is no diastole above and no diastole below also. This is the absent and diastolic flow. First, there will be increased resistance to the flow, followed by the decreased absence, decreased end diastolic flow, followed by the absent end diastolic flow, and last marker will be the reverse end diastolic. So absent end diastolic flow is associated, we should suspect some congenital malformations according to the system-wise: cardiovascular system, ventricular septal defect, hypoplastic left heart, double outlet right ventricle, Epstein's anomaly, and arrhythmias. In central nervous system, hydrocephaly, holoprosencephaly, agents of corpus callosum, urinogenital system abnormalities such as renal agencies, hydronephrosis, gastrointestinal system or abdominal wall, esophageal atresia, amphalocele, gastrocytosis, and skeleton systems such as polydactyly. So while doing TIFA, we should concentrate on those in all those anomalies. Another is next is the uterine artery Dopplers. So impedance to the flow in the uterine arteries decreases with the gestation. The initial fall until 24 to 26 weeks is thought due to trophoblastic invasion of the spinal arteries. And then again, there will be fall in impedance beyond 26 weeks also. This can be explained by persisting hormonal effect on the elasticity of the arterial walls. So this is the in uterine arteries Dopplers. We will see the picture as follows. This is the systole. This is the diastole. This is the normal impedance to the flow in uterine artery in the first trimester. In the second trimester, and this is the third trimester. See, as the trimester wise, if we are seeing the Dopplers, there will be increase in the diastolic flow and there will be decreased in the pulsatility index. See here, this is pulsatile. Here it's not pulsatile. It's almost, this is the peak systolic velocity and this is the end diastolic. Almost the end diastolic velocity is more than half of the peak systolic velocity. And in uterine arteries, we'll see a characteristic feature known as diastolic notching, early diastolic notching. That is normally it will be present, but because in we have seen the uteroplacental unit now, in that we have seen spiral arteries slowly they will be canalized by the cytotrophoblast and after that channelization will happens and the spiral arteries will be dilated. So if that's why this diastolic notching will be there. But at end of the gestation, means as the gestation age improves, this diastolic notching will be gone because the spiral arteries are almost dilated and it will become funnel-like and there won't be any impedance. So there won't be any diastolic notching in the uterine arteries in normal pregnancies. This is the pulsatility index in the uterine arteries as the gestational age advances. This is the 5th centile mean and this is the 95th centile. As the gestation age advances, the pulsatility index will decrease. If pulsatility index of both uterine arteries are normal, we can be sure that the mother won't develop any preeclampsia or IUGR. It will have a negative predictive value of more than 99%. So if in any high risk case, if we do the uterine artery Dopplers and we'll see if the pulsatility index are normal and uterine artery Dopplers are normal, we can reassure that the fetus will not be going to develop any IUGR. So, what are the features of abnormal uterine artery Dopplers? So, persistence of the diastolic notch on the placental side, especially, and resistance index more than 0.58 after 23 weeks of gestation, pulsatility index more than 1.45, and difference between the right and left ventricular systolic diastolic ratio more than 1, and uterine artery S by D ratio more than 2.6 after 22 to 24 weeks. So, I told you now all the indices should decrease as the gestation age progresses, but if they are increased or say it indicates abnormality, and especially in uterine arteries, persistence of the diastolic notch on the placental side especially is a caution. So uterine artery Dopplers we have did at 18 to 22 weeks of gestation. If they are normal, we will say means we will proceed normally. If they are abnormal, we will start the mother on aspirin after looking all other parameters, 50 to 150 mg, 50 to 150 mg. And we will repeat the scan at 24 weeks. If they are normal, we will follow up as normal, means normal guidelines. If they are still abnormal, then we will do 2 weekly biometry, that is biophysical profile and Dopplers, and we'll decide when to. We'll see other artery Dopplers and venous Dopplers, and we'll see when to terminate the pregnancy. So we have completed umbilical artery and uterine arteries. Now we come to cerebral artery, that is fetal cerebral arteries. So the PI, that is pulsatile index, is significantly higher in the middle cerebral artery compared to internal carotid or anterior posterior. And we do the MCA Dopplers only because it is easily accessible and we can easily reproducible also. That's why and easily accessible also. That's why we'll do the middle cerebral artery Dopplers, and flow will also be more in the MCA. So it is therefore important to know exactly which vessel we are sampling because PI value that may be normal for internal carotid will be abnormal for the middle cerebral artery. So the use of color Doppler greatly improves the identification of the cerebral vessels, thus limiting the possibility of sampling errors. The blood velocity increases with advancing gestation, and this increase is associated with decrease in the pulsatility index. So this is a color Doppler, circular villus with middle cerebral artery. So in the first trimester, this is a systole, and there is slow diastolic flow, normal flow of middle cerebral artery in the diastole. There will be diastolic flow is there here, see, in the second and third trimester. So this is the picture depicting the middle cerebral artery pulsatile index, and this is the velocity of the flow. So as the gestational age increases, the pulsatility index is decreasing, whereas the middle cerebral artery velocity is increasing. Velocity of blood. MCA, middle cerebral artery, is more sensitive to hypoxia. That's why we will prefer middle cerebral artery. And if we see high systoles in middle cerebral artery, this is the systole and this is the diastole. If we see high systolic flow in the middle cerebral artery. That means means more amount of blood is going. That is, viscosity of the blood is decreasing. That means indirectly it signifies the baby is going to fetal anemia. High diastole indicates brain sparing effect. So if the baby is IUGR, then only important organs like brain, adrenals will receive the blood compared to the remaining organs, leading to increased MCA flow and increased Dopplers. That is, high diastolic flow will be there. That is known as brain sparing effect. Middle cerebral artery velocity more than 1.5 MOMs means of median indicates moderate to severe anemia. And MCA velocity more accurate than the amniocentesis. So, for in case of RH isoimmunization or any twin-to-twin severe twin-to-twin transfusion syndromes, if you want to monitor, mostly they will do the amniocentesis and they will remove the and they'll collect the blood and they'll see the PCV and HV of the baby to decide to give intrauterine transfusion or not. So we can look at the MCA velocity also. If they are more than 1.5 means of median, then it indicates severe anemia, and there are nomograms and we can chart on that, and we can see when to give the transfusion, and we can avoid the invasive procedures. This is the picture depicting the fetal MCA velocity. So this is median. This is 1.29 MOM and this is 1.5 MOM. So A zone, that is this one, is mild anemia, and moderate to severe anemia is this B zone. This is normal. So here, so we have plotting the as a gestation wise, we are plotting the MCA peak velocities. So here in this graph, in the A, if the MCA peak velocity falls in the region of A, we should give the intrauterine transitions. If the peak velocity falls in the B area, we should repeat MCAs every 5 to 7 days. And if it falls in the C, 7 to 10 days, we should repeat. And if it falls, we should repeat in the D area, repeat every 2 to 3 weekly. Another important assessment is cerebral-placental ratio. Cerebral-placental ratio is nothing but we will calculate the MCA Doppler, MCA resistance index followed by umbilical artery resistance index. So MCA resistance index will be constant throughout the pregnancy, that is 0.75 to 0.85. So normally cerebral-placental ratio will be more than 1 because MCA by umbilical artery we will see the resistance index. So MCA will be constant, but as the gestational age increases, in normal pregnancy, the umbilical artery resistance also decreases. So the denominator will become less, numerator will be constant. So the ratio will be more than 1. That is normal. But in case of IUGR with brain sparing effect, what happens? MCA in middle cerebral artery, the flow will be increased. The resistance index will decrease further. But in umbilical artery, the resistance will increase, leading to the ratio coming to less than 1. That indicates fetal hypoxia. So reversal in the one of the important thing we have monitoring a pregnancy. So the MCA resistance index has been decreasing and the flow is increasing. So we are suspecting fetal hypoxia, but suddenly if there is a reversal in the MCA flow, that is an emergency indicating cerebral edema and it precedes the fetal death. We should intervene as soon as possible. Now we will come to the venous flows. One is ductus venosus Doppler. It indirectly tells about the right ventricular preload. So mainly used in early onset IUGR to avoid the premature delivery. Means if we are following with the mother with the umbilical artery, uterine artery Dopplers, MCA flows, there is a brain sparing effect is there in umbilical artery, reverse and diastolic flow is there, but the baby is very preterm, 26 weeks, then we will do the ductus venosus flow and see. Even ductus venosus, if there is increased resistance and PA is above 95th centile and reversal, we should terminate the pregnancy emergencyly. So it is strong predictor of outcome in these babies, usually affected only in the late stages, because if it is affected only in the late stages, if we see any abnormality in the ductus venosus, we should immediately terminate the pregnancy. And when it is absent or reversed, indicates advanced fetal compromise and perinatal mortality. Hence, delivery is indicated with this Doppler sign, irrespective of the gestational age. So normally venous flows will not be pulsatile, but if the venous flows are pulsatile, it indicates high morbidity and mortality, and raised ductus venosus PI above 95th percentile is also indicative of higher risk, but the risk is less compared to when it is absent or reversed. So this is the figure showing the ductus venosus normal flow. So venous flows will be normally in artery, what we have seen, this will be the systole and this will be the diastole, like that we have seen now. So, but here venous flows will have two upstrokes in the diastole. One is passive filling, another is filling by the atrial contraction. So there will be in systole, in case of venous flows, there will be two peaks in the systole. This is the passive filling of the atria, and this is due to the atrial contraction flow. So double peak in systole, this is the diastole. So this is not a pulsatile, this is normal flow. So, but in IUGR, what happens? Initially, it will be like this. There is a diastolic flow. Slowly, this is known as M shape also, that is normal. Slowly, the diastolic component is decreasing. This is the M will means the waves in the systole will become somewhat pulsatile with decrease in the diastolic component. Absent, first there will be decrease, then absent, then there will be reversal with the pulsatile pattern. This is the pulsatile pattern with the reversal of the flow. This is very dangerous, and we should terminate the pregnancy irrespective of the gestation age. Other vessel for Dopplers or aortic isthmus, it is a balance between the impedance of the brain and systemic vascular system. Reverse aortic isthmus sign is a sign of advanced deterioration. So aortic isthmus Doppler also play an important role in surveillance of early onset IUGR, but the changes in this Doppler can happen a week before Doppler ductus venosus changes. So may not have an acute predictive value in case of stillbirths, because in case of stillbirths, still it can be so we can't comment on acute deterioration if the aortic isthmus Dopplers are abnormal. But if they are abnormal, that is reversal in the aortic isthmus Doppler, it highly correlates with the adverse late neurological morbidity at 2 to 5 years of age, and immediate neurological morbidities such as intraventricular hemorrhage, periventricular leukomalacia changes. So it will have a neurological significance. So what happens in case of umbilical arteries in case of IUGR? So rising impedance is initially observed in fetal-placental circulation and is reflected in falling end-diastolic flow velocity and the rise of umbilical artery Doppler indices. So with continued deprivation, the blood flow is redistributed to favor the perfusion of vital organs such as brain, heart, and adrenals at the expense of flow to the muscle, viscera, skin, and GIT and other less critical organs. The cerebral redistribution is reflected in a decreased CPR, the cerebral-placental ratio, which is the ratio of the middle cerebral artery to the umbilical artery Doppler indices, as we discussed earlier. So with the brain sparing effect, the end-diastolic flow, initially it will be decreased and then it will be absent and then lastly reversed with significant worsening fetal status. These changes in end-diastolic flow occurs on average 1 week before the acute deterioration or clinical symptoms in the mother. Progressive decline of fetal condition is further manifested by the absence or reversal of the ductus venosus atrial wave, diminished and eventual loss of the fetal heart rate variability and reactivity. So initially there will be increased resistance followed by decreased diastolic flow, followed by absent end diastolic flow, followed by reversed end diastolic flow, followed by absence or reversal of the ductus venosus atrial wave A wave, and then lastly diminished and eventual loss of fetal heart rate variability and reactivity. So in case of fetal hypoxia, we'll see how the uterine arteries will be there. In pregnancy is complicated by preeclampsia and or intrauterine growth restriction. Impedance to the flow in the uterine arteries will increase. So increased impedance in impedance hypertensive mothers compared to the hypertensive mothers with normal flow velocity waveforms, there is a higher incidence of preeclampsia, IUGR, emergency cesarean section, placental abruption, short duration of pregnancy, and poor neonatal outcome. So this is abnormal development of the uterine arteries. See, this is the systole, this is the diastole, early diastolic notch. This is the normal impedance to the flow in uterine arteries, the characteristic waveform of early diastolic notching. So here, increased impedance to the flow in the uterine arteries with characteristic waveform of early diastolic notching. See how deep the early diastolic notching has become. And here there is very high resistance to the flow within the uterine arteries with reversal of the diastolic flow. So fetal arterial Doppler studies are useful in diagnosing small for gestational age and IUGR infants. In hypoxemic group, due to impaired placental perfusion, PI in the umbilical artery is increased and fetal MCA PI is decreased. Consequently, the ratio of PI in umbilical to the middle cerebral artery will be increased. There is no evidence that use of other peripheral artery vessels such as renal, splanchnic, or peripheral pulmonary arteries provides any means we can't get any other information apart from doing these cerebral arteries in case of growth restriction, growth restricted in fetuses. So in fetal hypoxemia, there is an increased blood supply to the brain, myocardium, and adrenals, and decreased perfusion in the kidneys, gastrointestinal, and lower extremities. So these are vessels which we have increased flow impedance. So decreased impedance is seen in cerebral, adrenal, and splenic and coronary arteries. In red blood cell isoimmunization, in red cell isoimmunized pregnancies, placentation is normal, and therefore the indices to the flow will be also normal to the uterine umbilical arteries as a normal pregnancy. But if there is no anemia, if anemia is there, then the MCA Dopplers, means the flow to the middle cerebral artery will increase, and the MCA end diastolic flow will be increased, and then the indices will be altered. In red cell isoimmunized pregnancy, blood flow velocity in the umbilical vein, middle cerebral artery, thoracic, renal, and fetal vascular system are increased in proportion to degree of fetal anemia. This main mechanism will be the hyperdynamic circulation of the anemic fetuses is decreased blood velocity, viscosity. So if the viscosity is decreased, there will be increased venous return and cardiac preload. In case of twin pregnancies with the fetal growth restriction due to placental insufficiency, the growth restricted fetus demonstrate the same circulatory changes as we have seen in singleton as of now. Thus, increased impedance to flow in umbilical artery is usually associated with the arterial distribution in the fetal circulation, demonstrated by decreased PI in the middle cerebral artery. So in pregnancies with severe twin-to-twin transfusion syndromes, there is decreased middle cerebral artery PI in recipient twins and decreased middle cerebral artery mean velocity in the donors. So twin-to-twin transfusion syndrome most commonly occurs in monochorionic twins. Umbilical artery Dopplers will have a prognostic role in these cases. Absent or reverse and diastolic flow with reversal in ductus venosus or pulsatile pattern in the umbilical vein suggests poor prognosis, means we should intervene immediately. MCA, middle cerebral artery, peak systolic velocity allows diagnosis of the fetal anemia and intrauterine transfusion, that is IUT need. This is the staging done by known as Grataco staging for insufficiency, stage 1, 2, 3, 4, mild placental insufficiency, severe placental insufficiency, advanced fetal deterioration with a low suspicion of fetal acidosis and high suspicion of fetal acidosis. It depends upon the findings and how to monitor it and what is the management. So in case of stage 1, there is mild placental insufficiency. The estimated fetal weight will be less than third centile. Cerebral-placental ratio will be less than fifth centile. Uterine umbilical artery PI will be more than 9/5 centile, or MCA PI will be less than 5th centile. Why MCA PI is less than 5th centile? Because due to brain sparing effect, this is a mild case of placental insufficiency, though brain sparing effect will be there. So there will be increased blood flow to the MCA and the PI will decrease. So what we should do in these cases, we should monitor the mothers weekly and delivery by 37 weeks, and which can try induction also. In case of stage 2, severe placental insufficiency, umbilical artery, there will be absent and diastolic flow. We should monitor them twice weekly and deliver by 34 weeks by elective LSES will be good. And advanced fetal deterioration with a low suspicion of fetal acidosis, that is in the umbilical artery, there will be reverse and diastolic flow, or ductus venosus, the pulsatile index will be more than 95th centile. Here we should monitor every 1 to 2 days and deliver by 30 weeks by elective LSES. In stage 4, high suspicion of fetal acidosis, that is this is a late sign, that is in ductus venosus, reversal flow will be there, reversal of the A wave with cardiotocography with short-term variability of less than 3 minutes or fetal decelerations. We should monitor every 12 hourly, and we should deliver by 6 weeks, or immediately we should terminate depending upon the clinical condition by elective LSES. This is a study done by Aditya et al. The Doppler and IUGR diagnosis. Here they gave a tabular form, means flow chart for managing. So in case of suspected IUGR, we should do the umbilical artery Dopplers. If they are normal, we should repeat Dopplers in 3 weeks. In case of high risk pregnancy, if it is elevated, then we should see how is the cerebral-placental ratio. If it is more than 1, it's normal. We should repeat the Dopplers in 1 week. If it is abnormal, we should see what is the gestation. If less than 31 weeks, we should monitor the ductus venosus, because ductus venosus, if it is any changes, then we should terminate immediately. In 31, 34, we should check ductus venosus flows, BPs, anything abnormal, we should see. If it is more than 34 weeks, we should consider the delivery, because prematurity will also have its own risk, morbidity and mortality. That's why we will prolong the pregnancy. If the CPR is normal, CPR is normal, we will wait. CPR is abnormal, we'll see the gestational age. If it is more than 34 weeks, we'll consider the delivery. In umbilical artery Doppler, if it is absent or reverse, then we will see the ductus venosus and BPs daily. If either of them becomes abnormal, we'll consider the termination. So thank you. Any doubts? Okay, then we'll end the session.